the survey is a link here. Can you see that on the screen now, Natalie?
I can, yeah,
The
thanks.
survey? Okay, that's great. Okay. All right, well, I think we'll get, sorry, go ahead.
Barry, there's someone in the chat that's asking if there's a phone in.
No, there's not. Okay, I think we'll go ahead and get started, everyone. This is a little bit different. We're running today's meeting as a webinar format so we can handle more members than we normally have. We typically have about 80 members, 85 members. And I see we've already got 123 attendees and the number keeps climbing. So we expect it'll be a fairly well-attended meeting today. And for those of you who are in the environmental hygiene interest group already, it is time for elections for new members. And so the positions that are available are chair, vice chair, and secretary. I've put up on the screen here a survey that is being sent out by the environmental hygiene interest group today. I don't know if everybody's received it yet or not, but if you are interested in running for one of those positions in volunteering or nominating somebody for chair, vice chair, or secretary. We'll talk about that at the end of the presentation today, and we'll give everybody an opportunity to host elections. If we don't have that, we would ask you to please consider running for chair, vice chair, or secretary after this meeting and letting us know. That is part of the needs assessment survey that's been sent out, is asking for volunteers for the executive going forward. Also in there is a request for you to let us know what you found valuable over the last few years and what you would like to see over the next few years. So you should all get that in your inbox here shortly from IPAC. And I think, Natalie, we could probably include that with the minutes, a link to this survey as well after this meeting. Okay. All right. So without further ado, I'm going to introduce you to our panelist who's going to introduce our guest speaker for today. So I'd like to introduce Danielle Kane. Danielle is a master's student in epidemiology, infectious disease, and she previously had worked in IPAC. And I'll let you tell your story yourself, Danielle, a little bit, and then if you don't mind introducing our guest speaker for today.
All right, thank you, Barry. It's great to be here today. So as Barry mentioned, I'm a master's student studying infectious diseases with the London School of Hygiene and Tropical Medicine. I'm also a research assistant with a project going on at Concordia University looking at zoonotic disease spread. And I also work with CAPM, or the Canadian Association of PPE Manufacturers, as a clinical specialist too, as well as being involved in other COVID-19 safety advocacy initiatives. I'm really excited today to be able to introduce Dr. Victor Leung today. I think this will be a really great discussion. So thank you, Dr. Leung, for being able to join us today as well. Dr. Leung is an infectious diseases physician, a medical microbiologist, and a medical director of IPAC with Providence Healthcare in Vancouver, BC. And he also served as an IPAC Canada board member in the past. So today, Dr. Leung will be discussing the current knowledge of airborne spread or transmission of SARS-CoV-2 and how this relates to IPAC practice as well. So I will now welcome Dr. Leung to begin this conversation.
Thank you, Danielle, and thanks to all the participants for taking time out of your day to join this. I'm just going to switch over first to the share screen. Does it work now?
Okay. Good.
Sorry, I have to do something else to get the Zoom screen off my Okay, well, that doesn't seem to work. I think that'll be fine. So thank you for the opportunity to speak to the IPAC, Canada Environmental Interest Group today. And I think there are other members joining as well. I've talked about this topic quite a bit in different forums to, for example, medical staff, nursing staff at our hospital, and also during town halls. But I can tell you that there's been a change, and that this wasn't what I was always understanding or believing in terms of transmission. So at the beginning of the pandemic, if you recall back in kind of when Canada and most hospitals were doing things in their hospital to prepare, the message that most of us received was that this is primarily transmitted through droplets, and that's why we need droplet and contact precautions, and that would be sufficient in protecting both healthcare workers and patients from infection. And very few people in IPAC, infectious diseases, public health, ever challenged that. But I think as the pandemic progressed and we started to see more events publicized, both in terms of scope of spread in super spreading events, as well as our own experience in dealing with transmission in hospitals and seeing what was going on. There are many people, including our group and myself, who kept thinking, well, maybe it was just that staff are not following adequate PPE. Maybe we need to do more training in donning and doffing. Maybe there are incidences where we just aren't seeing what staff are doing, and that's leading to transmission. And very few of us questioned why there was such large outbreaks continuing despite our efforts in environmental cleaning, proper donning and doffing of PPE. And it wasn't until recognized publications later on that I'll go through some of these that really started to tell us that the preponderance of evidence supports airborne transmission as the predominant and primary route and most important route to try to mitigate if we want to prevent transmission. And so I think part of this, my desire to kind of talk about this more and understand this more has to do with acknowledgement that personally I've made a mistake, and I think it's important to acknowledge these errors and then to own it, as well as to learn from it and then tell others about it. So I'm just taking this opportunity to hopefully share with others some of this history and why it's very important to reduce airborne transmission if we are to target infection control measures that are going to have impact in this pandemic. So there is a huge kind of history related to infectious diseases and transmission. And if we think about different modes of transmission that we frequently talk about now in this framework of contact or droplets and airborne, really the contact framework started early on with Semmelweis and recognition that transmission of group A strep and puerperal fever was really due to hands and hand hygiene. Later on, we can see that with diseases like cholera, it is really truly a waterborne disease as opposed to an airborne disease. But this idea of air transmission or airborne transmission goes back to a very long time ago with Hippocrates, with the miasma theory. And this really was the predominant theory about transmission of infectious diseases for a very long time, until it was later on when we started to recognize this contagion theory in the 1850s. And Charles Chapin, who I will provide a reference to later on, and his discoveries in 1910 as one of the most famous American epidemiologists involved in also co-starting the US CDC. At the time, really thought that droplet transmission could then explain much of what was missing in the past, and tried to shift this pendulum for us to think about how we could better control diseases through control of droplet transmission. But a lot of this at the time was contextual, because most people's theories and how they develop it and their mental models are going to be based on the context historically of what was happening, as well as what was available to them. And really for Charles Chapin and the US CDC at the time, it was to convince individuals that if we could shift people's thinking that diseases may not just be in the air, and makes it very difficult to control because at the time they didn't have as many tools. And maybe we could then convince people that personal hygiene, environmental hygiene was important, and that we can actually do something about it to control disease rather than just take a defeatist approach that if this were airborne, we weren't able to do anything about it. And that would lead people to, I guess, just accept that infection will occur. So it was a framework and a mental model that they used at the time to try to explain things, but also make it practical for people and take a pragmatic approach. But it wasn't until the 1930s when Wells and then his colleague Riley, Wells was an engineer based out of Boston and did a lot of his studies in Maryland looking at airborne transmission of TB, because he truly believed at the time that measles and TB were airborne pathogens. But it wasn't until his experiments that were fundamental in establishing that tuberculosis, Mycobacterium tuberculosis, was predominantly transmitted and only obligate transmission through the airborne route. That wasn't established until 1968 through many of his experiments using a hospital-based lab, where on the roof of the hospital TB ward, they were able to connect ducts to chambers for guinea pigs. And you can see that over time, the guinea pigs were being infected. The only way that that could happen was through airborne transmission. Now in the mid to late 1900s, they have established that TB, measles, smallpox, chickenpox are all airborne pathogens. And soon in 2003 with SARS, it wasn't until some of the further engineering studies that were done that established airborne transmission. We know with influenza, there is a significant airborne transmission component. Same applies to MERS, and now with SARS-CoV-2. Now it was interesting with SARS because the WHO has said previously that we are not aware of any viral pathogen that has changed its main modes of transmission. And knowing that SARS in 2003 was airborne, how could SARS-CoV-2 not be airborne as a coronavirus that was similar in some aspects? So this fundamental shift really occurred because of the availability of PPE and also some hesitancy by the WHO to communicate to the public how transmission occurs, because I think at the time they realized that there were not enough infrastructure given the current framework of how we manage airborne infections to be able to disseminate this widely and communicate this in a way that they thought would not create mass fear or paranoia. And I remember back in February, March, when people were wearing masks in hospitals, IPAC and across the province was asked to actively discourage people from masking. And so our shift in thinking and understanding about this disease has changed significantly. In fact, in 2021 now, we recognize that a significant, looking back at the evidence and the quality of the evidence and the logical fallacies, we now recognize that respiratory viruses in general have a significant airborne transmission component. Sorry, I'm just trying to shift the slides. Okay. I'm not going to go through this in too much detail given the time, because I do want to reserve time for more dialogue with members in this group. But thinking back to Semmelweis, we knew how much problems he had in trying to convince his peers, the public, about transmission, because at the time people just said it was in the air, and puerperal fever had nothing to do with transmission through hands. And it was not only until after he died that it was finally recognized the significance of hand hygiene and ability of people to transmit this disease through touch. And We know with cholera and the outbreaks there, John Snow also had a very difficult time convincing people that this was not an airborne disease, but a waterborne disease. And it was only not until 1866 when he was finally vindicated for his work in establishing the importance of recognizing primary mode of transmission being waterborne. And Florence Nightingale very early on recognized the importance of good ventilation in hospital wards. You see these large hospital wards with open windows, allowing airflow from through the windows and improving ventilation that way. And in this movie, Outbreak, I think that also had a significant impact on how we view airborne diseases, because, like I said, I feel that the US CDC, PHAC, and WHO were slow to acknowledge this and reluctant to, because if we think about our existing IPAC framework for managing airborne diseases, it entails respiratory protective equipment in the form of respirators, but it also entails an environmental infrastructure, which is an airborne infection isolation room. And we know in current hospitals, at least in hospitals in our province, in BC, that airborne infection isolation rooms are very hard to come by. So I think at the time, if they said, this is an airborne pathogen, many places would have just said, we aren't able to deal with this. How are we going to compensate? So instead of changing the framework and recognizing that although you may not have perfection in environmental controls, you can still have protection for your staff and patients through respiratory PPE, and that you don't need perfection in achieving airborne infection isolation in all places. I'll tell you a bit about what our hospital did later on in the presentation to address this. So in this movie, they recognized that when patients were getting infected, acquiring infections in the hospital, the only way that could have occurred was through airborne transmission, because the only connection through these hospital rooms were through the HVAC system ducts. And we've seen in multiple epidemiologic studies in apartment buildings, for example, how air will take the route of least resistance and go through multiple barriers. So where are we at with the evidence in airborne transmission? Now, this is from a colleague, a physiatrist in Ontario, Dr. Jennifer McDonald, who was interested in this as a physician, seeing how things were being managed at her hospital and what was happening in Ontario, and just went through the various types of evidence using the framework to establish how do we prove something is airborne, because the threshold for showing airborne became very high, partly because of the history of the pendulum swinging from one side to the other. And so people didn't really want to call something airborne unless they were very sure. So the levels of evidence and the types of evidence, for example, nosocomial outbreaks, animal models, human challenge studies, all those are variable in terms of the various diseases we have. But if you look at this table here, and it doesn't show the whole table, but we can provide a reference for that, the burden of evidence now showing that SARS-CoV-2 is transmitted through the airborne route is huge compared to many other infectious diseases that we already recognize as airborne. So it does make us think, why is this threshold continuing to change, or the goalpost continuing to change for those who continue to deny the importance and the predominant route of this transmission? So I'm not going to go through all these studies, but these are just a few examples of super spreading events. So for example, in the Diamond Princess cruise ship and the importance there, animal studies where the only way of transmission is proven through, similar to how TB was established, that the only route of this animal transmission is through the aerosols or airborne transmission. We have large reviews in the journal Science, as well as other highly regarded publications that explain both historical aspects as well as the evidence. So just looking back at routes of transmission, you can see that if we think, well, what is the chances of direct or indirect contact? And through these modeling studies, we now understand that the risk of contact transmission is very low, less than 1 in 10,000 for every touch, if there was a significant virus there leading to transmission. And people used to think that droplets were important, primarily because of this idea of proximity versus aerosols. But now we have increasing evidence and specific studies that are enabled by our colleagues at Aerosol Science to be able to visualize and also separate sizes of particles to determine which particles actually have the most virus in them. And aerosols, which we now know are less than 100 microns, are really the predominant mode of transmission, whether it's in close proximity or at a distance. And also that these particles, although there are less than 100 microns, behave differently depending on which part of the respiratory tract they are inhaled to in terms of the distance. So in this simplified visual from Dr. Lindsay Marr, one of the leading aerosol scientists, you can see that when you are in close proximity to somebody, the number of particles that are generated are significant. But the number of particles that fall within this droplet size, which is 100 microns, are actually very few in comparison to aerosols. And these droplets are larger than 100 micrometers and generally fall to the ground within 1 meter. And that's why we have this 2 meter distancing that was established because of a safety margin. But really they fall to the ground quickly. And so in order to truly be infected by a droplet, that droplet would have to land on mucous membranes that are connected to your respiratory tract. Those mucous membranes would have to lead to areas in your body that have the humanized ACE2 receptors for this virus to infect. So really droplets can be thought of as spray droplets that would land on the mucosal surfaces. And when we think of our body mucosal surfaces, what is the surface area of our conjunctiva or our eyes? What is the surface area of our mouth, lips? And how likely is that to really land on there and then cause an infection? Compared to the surface area of the respiratory tract, which once you get down to the lungs and the alveoli is significantly, million times higher than the surface area of those other mucosal surfaces. So when you inhale particles, those particles, depending on their size, can land in different aspects of your respiratory tract. Larger particles will end up in the upper respiratory tract, possibly around the nasopharynx. Smaller particles will end up in the bronchi, the main bronchi. And then smaller particles, which are those respirable aerosols less than 5 microns, those are the ones that get deep down into the respiratory tract. And when we think about that, it does explain to us why we have these cases sometimes where initially on sampling, we get negative samples in the nasopharynx and positive samples in the lower respiratory tract. That's not necessarily because of progression of disease from the nasopharynx down. It could possibly be explained by inhalation of aerosols that are infectious down to the lower respiratory tract, replication of this virus, and then soon an ascending phenomena where you actually are able to pick up the virus from the upper respiratory tract versus lower respiratory tract. Now, this has been explained very well in the science review by Dr. Xia Wang and colleagues that illustrate in the left panel these respirable particles that end up in different areas and that talks about the phases of transmission from phase 1, generation of these aerosols that are infectious, to the transport of these aerosols in the environment that are going to be impacted by factors such as relative humidity, temperature, and also the ventilation of the room. And for example, if your room has advanced measures to control infectious particles such as upper room UV or good airflow with portable HEPA filters, then you're going to have less of a chance of these aerosols being lingering in the air for prolonged periods of time. And then finally, phase 3 is the inhalation of these aerosols. They've also done a very good job comparing the different levels of evidence, comparing the viruses listed there on the right panel, and the evidence done through air sampling and PCR, air sampling and cell culture, being able to culture replication competent virus, studying this in animal models, epidemiologic outbreaks that have been very carefully analyzed, most of the time including use of closed circuit television with hours and hours of review of what people are actually doing in these closed spaces, and showing that there really is zero contact in some scenarios, such as the choir or the singing event that took place in a church. And they can see that there was zero contact among these individuals. So the only way that they could have acquired this was through the air. And then a particle segregation studies, being able to segregate these particles into the different sizes as being droplets or aerosols and knowing which ones have this. I think it is important to note, because I've heard this so many times by infectious disease physicians, public health physicians, that initially they were saying, well, this is not a classic airborne pathogen because the reproductive number doesn't fit with measles. Well, if we actually look at the reproductive, if we took their logic and looked at the reproductive number of tuberculosis, which is quite low, or influenza, and we compare it to SARS-CoV-2 with the Delta variant now, we see that reproductive number is actually higher for SARS-CoV-2. But let's not fall into this trap of going through their logic and actually think about what reproductive number means. So the reproductive number is a measure of the average number of cases an individual who is infectious will transmit on further. So if the reproductive number is 2, it means the average number of individuals that are infected by a source could be 2. But with SARS-CoV-2, the other factor that's not presented is the dispersion, the K. And we know that the super spreading events inform us repeatedly that this is a highly dispersed virus, meaning that the reason this pandemic is propagating is because there are individuals who are at high risk of transmitting to others and do so transmit to a large number of individuals. These super spreading events are largely going to be informed by the environment that a person is in. So closed, poorly ventilated spaces facilitate these super spreading events. While in reality, the majority of individuals don't go on to transmit to a lot of other individuals. Some people are dead-end transmissions, they don't transmit at all, and some people might transmit to one. But you have these other super spreaders, super spreading events, where one individual can go on to transmit to 10, 20 individuals, for example, in a spin class. And so it's these events that lead to this over-dispersed phenomena that we see with the SARS-CoV-2 virus. And the second factor to acknowledge is that the reproductive number is just that. It tells you the average number of individuals. It doesn't reflect the mode of transmission. An airborne transmitted pathogen doesn't necessarily equate to a high reproductive number, because we know that transmission is influenced by many factors and not just the mode of transmission. It's influenced by factors such as the viral load in the individual, how infectious someone is during their contact with other individuals. Many people are no longer infectious, even though they have detectable virus samples in their repeated NP swabs or ET tube aspirates. So really in SARS-CoV-2, for the majority of individuals, your infectious phase is very short. And that's why testing and identifying those cases is so important, but also why it's been difficult to control this pandemic. For the public, the science paper has been translated now into 22 languages, I believe, and also made simplified so that elementary school students can understand what aerosols are. So once this mental model has been established and we can communicate this properly through effective scientific communication, I think that we will be doing a much better job in preparing ourselves for future respiratory viral pandemics, as well as being able to control some of the transmission that we're seeing now. And moving on to, I'm almost done. Moving on to the next part, which is aerosol generating medical procedures. I know at the beginning, many of us sat through hours and hours of reading literature about AGMPs. But I think when we searched for this literature, we didn't necessarily able to find all of it because our search terms may have been influenced by our knowledge about how this was indexed. So if you look at the search term airborne, for example, and infectious diseases, quite limited, and it's not going to, if you ask a medical librarian, it's not going to capture a lot of the work done by our scientists in physics, in bioaerosols, in atmospheric chemistry. And so what we've been essentially doing in medicine is limiting our scope and trying to look for evidence within this medical field, not recognizing that there's this much broader field in physical sciences that we've neglected and failed to understand. Now with the improvements in our understanding of particle sizes and working with groups outside of medicine and infection control and public health, we are now able to show that our framework for aerosol generating medical procedures is also flawed. It was lumped together in terms of our lack of understanding of the details of aerosols and how they're generated. And we now can show that basics like talking, exercising, shouting, or coughing generate a significant higher load of aerosols than procedures such as high flow nasal oxygen, non-invasive positive pressure ventilation like BiPAP and CPAP, and also even intubation. So this is just one study example showing that intubation, showing that non-invasive ventilation actually generates a lot less aerosols than other basic activities. But what do we do in terms of recommendations? We've switched it around. We've provided higher levels of respiratory protection with N95 respirators when the risk is actually lower. And in fact, if we look at ICUs across the world, who ends up in ICU? It's usually individuals who are at least 9 to 10 days out into their disease, into their infection. By the time they're 9 to 10 days out, the majority of those individuals, even though they have detectable virus by PCR, are much less infectious or non-infectious compared to individuals during their acute phase of illness. So really where people are at higher risk is on the COVID wards or on your general wards where you might have an established start of an outbreak, where you have the highest viral load in people who are clustered together in shared 4 bedrooms versus in an ICU where someone's already past their most infectious phase. Of course, there will be exceptions of immunocompromised hosts, those who have significant B-cell and T-cell immunocompromising diseases, where they may have much longer courses of viral replication and infectivity. And finally, this is making its way into mainstream journals that are read by a large group of physicians. So this is published in the Annals of Internal Medicine, a narrative review on our current understanding of respiratory virus transmission and its implications in infection control. And what that tells us is really separates in one of the tables our pre-existing framework of how we thought these diseases were transmitted, and now with this increasing evidence, what we should be shifting our focus towards and providing considerations. And I would say that some of these considerations should no longer be considerations. They should become the standard in our infection control practice. So I encourage you to look at this article because I think it's very informative and does shift our thinking into doing things that are going to have value. And I think the sooner we do that, the better it is for our patients, for our colleagues in healthcare, but also it's going to impact our credibility. The longer we hold on to these beliefs that have been shown now to really been not correct, I think the earlier we recognize it, the better working relationships we will have with our colleagues as they see in the general medical literature telling them something different than what we've been telling them in the past. And finally, when it comes to respiratory protection, there has been a exciting new development. So the CSA, which we all refer to, we're referring to it at our hospital a lot now with the redevelopment of new hospitals and how we build new buildings that hopefully are going to be more infection resilient for our patients and our healthcare workers. This new CSA standard looks at respiratory protective equipment, and is really the replacement of the previous NIOSH standards for N95s. This Canadian N95 standard, or CA N95 standard, includes an important recommendation or criteria, which is going to become a standard on breathability, because we know that with these old existing N95 cup-shaped and stiff respirators, not only are they uncomfortable because they hold on with a very tight fit, but also their breathability is very poor compared to some of the newer innovations that we have. So Health Canada will be updating their guidance on these respirators, and it's really important for us to be working closely with our occupational health colleagues, occupational hygienists, to understand how we can procure supplies that are going to be accessible and comfortable for our healthcare workers who have been suffering sometimes through this with poorly fitting respirators. And that leads to a lot of consequences. Not only does it increase waste, as people just take off the respirator, replace it with a surgical mask, but it also increases the chances of transmission, especially when they're taking off a respirator in an environment where there could be infectious aerosols. So this new standard really is aiming, the CA-N95 standard is aiming for exhalation, pressure, and resistance to be, and also exhalation resistance to be much lower. So if we think of our traditional blue hard cup-faced N95 respirators from 3M that we see often on the wards, that has a 343 pascals for inhalation and 245 pascals for exhalation, versus this newer standards around 100. And for those who have tried the, for example, Aura, the 3M Aura 1860Ss, those are much more comfortable. When I'm on the COVID ward, I could wear it for half my shift, go for lunch, and then wear that again for the rest of the shift. Versus these old ones, I would not be able to, it would be with a lot of duress to be able to leave that on for 8 hours a day. And I think that type of discomfort also leads to our healthcare workers' misconception that they would not be able to wear a respirator for prolonged periods of time, when in fact we have these newer standards. And this type of newer standards will also drive innovation. If we think about the waste that these masks create for the environment, and the importance of planetary health, and how healthcare as a sector is a big contributor to waste and environmental impact, we can develop better tools now to have reusable respirators, or that are not only more comfortable to breathe in, but also less waste for the environment. So hopefully this sets the stage for changes. And I'll refer you to this excellent historical review for those who are interested in looking more at the history of the pendulum shift from the miasma theory to the droplet dogma, and now how we go back to recognizing that this droplet dogma needs to be not buried, but recognized where in the historical context it fell apart and no longer worked. And now we have this newer concept of understanding respiratory pathogens and how we can create infection prevention and control solutions to address this in a targeted way. So that's all I have to present, and I'm looking forward to discussion that hopefully will be moderated by Danielle, or even if we're able to do this live with unmuting participants. I'm not sure how this works.
So thank you very much, Dr. Leung. And we do have some questions, 2 questions in the Q&A right now, as well as a number of conversations going on in the chat. So I think we'll refer to the Q&A initially, and I don't know if you're able to see it. The first question, anonymous.
Will people be able to ask this live, or is it just typing? Because I know sometimes people.
I think it's just typing for now, because we have close to 200 people online, and it might be. I can try to let's do the typing for now.
Yeah, sure.
If we have time, I'll try and unmute individuals for discussion. I'm just not sure we'll have time though. So the first question was, are we differentiating between airborne large and small droplets versus droplet transmission and traditional airborne transmission? And that question came in fairly early. I think that was probably mostly answered through your presentation. I don't know if you have any further comments on it.
Yeah, we are differentiating. And I think it's very important to differentiate this with our new knowledge, because this size particle has been a major error in our textbooks, in our journals, in our guidelines, and even in our exams. When we think about particle sizes and how they behave, it's very important to be accurate. And aerosol are particles that are less than 100 microns, and they behave differently because they can stay suspended in the air for longer periods of time. And they are most concentrated closer to the source. Once you are removed from the source of an infectious person who's generating aerosols, or even non-infectious person, these aerosols are still generated, you will have less exposure to these aerosols as the concentration decreases because of ventilation and flow of air. Droplets that are greater than 100 microns behave differently in that they fall to the ground within a short distance, generally a meter, possibly up to 2 meters from an emitting source. And when we're doing normal activities such as breathing, that generates aerosols as well. So I think it is very important to differentiate these particles, and that this knowledge should change how we communicate and educate our trainees, because only with that understanding can we truly then explain and reconcile these differences. And some people have said, why don't we just call these particles, just lump it all together as a continuum? So it is important to recognize it is a continuum, but when we have knowledge about how this different particle size behave in this continuum, I think it is very important to be clear about this.
Do you have any information as to why dentistry, which constantly creates aerosols from the oral cavity, has had very low transmission rates, very low illness for oral healthcare workers?
Yeah. So first of all, low is not zero. Our target really for healthcare workers should be zero infections. And I would look at the data carefully to understand, okay, is it a true representation? Do we have good capture across the world of transmission to dentists? And in what setting dentists are being infected and not being infected? So dentists as a profession already have greater levels of protection. And after the pandemic, they did a lot more to reduce infection risk. So most modern dental offices now have much better ventilation than, say, a hospital room. Close proximity, they have devices that suction. And if you go to your dentist office, you should ask them, hey, what devices do you have to minimize aerosol spread? And they can tell you all about the devices that they have purchased to improve the safety of their environment. And being in close proximity to someone definitely has a higher risk, but ventilation not only improves and has impact on someone who is at long distances from an individual, but also now we know through modeling studies how ventilation that is able to achieve 10 liters per person, and it is able to also reduce transmission at close proximity. So I think the field itself are related to this question about dental transmission. There are several factors. First of all, looking at truly, do we have good data to inform us about transmission among this group of healthcare workers? And secondly, looking at the environmental measures that they have done, as well as the personal protective equipment. Because the PPE that we use is not zero in terms of its effectiveness. Our surgical masks, our eye protection and face shields have an impact, but also your risk of infection is going to be influenced by who you are in contact with and at what stage of their illness. During the pandemic, the dentists also significantly decreased the number of patients they were seeing until these measures were introduced to improve transmission risk. So I think those factors help explain why there might be this observation that some healthcare worker groups are at lower risk.
Right. Thank you. I think Natalie wants to get in. I do want to make one quick comment. I know here in Ontario, the dental hygienists, and then shortly followed by the Ontario Dental Association, put in rules for mitigation, including fallow time between patients, minimum ventilation and air filtration, and N95 respirators very early on. So by about April 2020. And they were the first group that I saw take a very active role. Anyway, sorry, Natalie, I think you wanted to speak. Probably time for elections.
No, not at all.
Okay.
I really like, I think it's Oscar's question. Perhaps if you would take his and then I'll jump in after that.
The which, sorry?
There is a question in the chat box, thanking you first for your presentation. And then if this is all true, how is it that all of us in the frontline healthcare workers working with COVID-19 patients at close proximity did not all end up with positive SARS-CoV-2 prior to vaccination being available to us? How did we not have a super spreading event occurring on a daily basis in hospitals on a daily basis? And I just add to that, that there's evidence to show, to Oscar's point, that the incidence in the healthcare worker is not greater in the community, yet the probability of risk is greater. So I'll pose that on Oscar's behalf.
Thank you. Yeah, I'm glad that question was asked, because I think I would break that down to several levels. First of all, I think, so to make sure I have all the questions in mind, that I don't forget to answer some of that was mentioned. So first of all, I think it's important to think back to when individuals are infectious. We know that individuals are likely to be reaching close to the peak of their infectivity before symptoms are established. And because symptoms are really just a host inflammatory response, that could be a variable time period. Generally, most people have taken 48 hours, but in some individuals, it can be much longer than that if they're symptomatic or asymptomatic. And so that's where the phase of transmission is the highest risk. By the time someone develops symptoms, they aren't going to enter healthcare as an outpatient generally right away. It'll be maybe a few days. By the time they get a diagnosis, another few days. And so if we look at the majority of time, people are infectious at most up to 7 days. And after that, they're no longer infectious. So even for a lot of the people who we're seeing on COVID wards, who are admitted as an outpatient, they are no longer infectious. And so that is one factor in reducing risk to healthcare workers. The second factor is depending on your hospital environment. Maybe there have been improvements already made. So for example, on our COVID ward, very early on, our facilities were very diligent in meeting the ASHRAE standards, doing assessments of air changes per hour, truly using thermometers, anemometers, looking at inflow, outflow, rebalancing, and then placing in portable HEPA filters that were exhausted to the exterior. So we were able to create air changes per hour that were much higher, and also to some degree negative pressure when you have the door closed with these industrial grade portable HEPA filters that bring exhaust to the outside. So all those measures helped in our hospital to reduce risk. Now, it's not true when we say healthcare workers are not at increased risk. If we look at the global literature, we have significant evidence that healthcare workers were at very high risk compared to some other professions. And that really depended on the context, who you're admitting to the hospital, when you admit people to the hospital. If you look at the number of outbreaks across the country in Canada, and you look at acute care facilities and long-term care facilities, those are examples of super spreading events. What happens in most acute care and long-term care facilities is you don't shift patients necessarily in a timely way away from a unit that's not a COVID ward. You may have one individual, transmission through the airborne route in a shared bed room, transmission through the hallway to staff, transmission to staff in close proximity. And then you start to seed this environment on a closed ward that's not necessarily a COVID ward. And as your respiratory viral load increases, you start getting more and more transmission. And I would say that for many of these large outbreaks, that's how transmission has been occurring. Yes, if you're lucky, then you will be maybe clouded by survivorship bias. I didn't get infected, so this must have been working for me. In fact, you actually may have been asymptomatically infected, or you were lucky in that you weren't infected because of the stochastic nature of transmission. This transmission does definitely increases when you have multiple individuals. So I would say that this is incorrect in assuming that we aren't seeing healthcare workers affected. Just because it hasn't happening on a day-to-day basis doesn't mean that the transmission modes are adequately controlled. It just means that by chance you don't have the right environment for transmission and super spreading to occur. But we have seen multiple large outbreaks occur because of this, and not because of healthcare workers not being diligent with their PPE. We need to stop blaming healthcare workers for that. And this reference to, well, there is some research showing that healthcare workers aren't at higher risk. And I can tell you that one article I'm aware of that was published by PLOS ONE by Annalie Yassi and colleagues at Vancouver Coastal has come up with this claim. But there are multiple limitations to this, and I may not be able to get into all, but I think the fundamental flaw in this study is that they compared healthcare workers in a time frame just prior to vaccination, when we had different variants. And what they showed, or what they have claimed, is that healthcare worker rates of infection are not higher than the community. But in an observational study like this, one of the key points that needs to be taken into consideration is, what is your comparison group? And if you look at their comparison group, they not only included the population level in the Vancouver coastal health area, but they included the denominator of Fraser Health. And at that time, where was the highest risk of transmission and the highest rates in our province? That was Fraser Health. So you take a comparator group that includes this general population of Fraser Health. So no wonder you're going to show that healthcare workers are going to be at not at an increased risk compared to the public, because you've already biased your study to come up with that result. And as a result, they've come up with this claim that I know that they are perpetuating. I know that there's a town hall on it tonight at Vancouver Coastal saying that this is adequate respiratory PPE, but also it goes against this primary fundamental of healthcare worker safety. Even though they aren't able to show that healthcare workers were at increased rates because of their poorly designed comparator group, whether by intention or by lack of study design acknowledgement. It also didn't include long-term care facilities and private facility workers. It only looked at the database, the white database, which includes healthcare workers who are non-employed, that are employed by the facility, and this makeshift physician group that they had that was included. So as a result of that, those limitations in the study, and this fundamental principle that healthcare worker infection rates shouldn't be higher, I would argue that that goes against the fundamental principles and our practice of occupational health, which should be that healthcare workers should be protected at work, and they should have the knowledge to protect themselves outside of work. So the fact that you're still getting transmission that is as high as the general public suggests that you're not doing a good enough job in protecting your healthcare workers at work and outside of work.
Right. Okay, well, thank you. I think we could go on and on with that subject. On a little bit different note, IPAC Canada.
Sorry, Barry, I'm just going to jump in there. It's Natalie. I just want to make it, I don't believe anyone said that they weren't at risk. It was the comparison they were quoted, but I do want to highlight a point that you're making, Dr. Leung, is that they're really, what was available at the time of that study for an observational study was really, that's all that was available. I'm just wondering if I may jump in. I have to leave at 3. I didn't realize we were going beyond. We do need our elections. And one of the nice things would have been the opportunity to look at some of your references that you made. Could you I think Prather, when talking about reducing transmission of COVID, there was some statement that you had made, and I think I saw 95%. But when you read that article, there was really a lot of emphasis on the importance, and I really want to make sure that we get your opinion on this, in really the focus on the ventilation and the continuum of the size, because you did mention that at the end, but I would like our audience to hear from you in regards to those 2 points.
Sorry, could you repeat which reference? You said Prother reference for 95%. I'm not sure which slide you're referring to.
Yeah, there's been a lot of discussion about it being airborne, but I think one of the things at the very end of your talk, which I really liked, was the continuum of the significance of the size. And then also, which I think we know now with lots of evidence to suggest as important the ventilation. And so I think that we almost see several factors that are contributing to this. And you did mention that your hospital setting had really focused on ventilation. So I just want to make a point of the importance of those 2 factors as well.
It just got cut off. Can people still hear me?
Yeah.
Okay. Yeah, I think I got the gist of the question. So yes, it's important to acknowledge that particles come in a continuum during normal physiologic activity with different concentrations or amount of particle sizes that fall within different ranges depending on the type of activity that's occurring. This has been very difficult to model because specifically and anatomically where things are and how much is produced. What is able to be visualized and observed is particle segregation through devices such as the G2 machine that's able to separate particles and then take those particles to determine how much virus there is in them through PCR. Also observed the number of particles visually can be seen as another tool. And so depending on the type of activity, yes, there may be more droplets visualized when you're coughing compared to breathing, in which there will be very few droplets compared to aerosols. But even during activities such as coughing, the number of particles that are in the aerosol size are much more significant compared to the number of particles that are of the droplet size. And so when we talk about ventilation, which is the act of replacing indoor air with outdoor air, and how many times that air change can occur during an hour, there are different modes of ventilation, whether it be opening a window, such as natural ventilation, or mechanical ventilation, which really requires the expertise of people who understand HVAC systems and are certified in dealing with that. Improvements with ventilation really only have an impact on aerosols.
Thank you.
Droplets are not necessarily be affected by this because of their size. And so it's important to recognize that when we do an intervention, what impact it's having on the particles. We've seen the ability of ventilation and added filtration itself to decrease particles in different studies, and also with the 95% part, I'm still not sure what you're referring to. It was one of the slides I presented. I know that one of the studies done by Don Milton's group, Christine Coleman's group, they were able to segregate the particles and look at where the burden of virus was really 85% in particles less than 5 micrometers.
Yeah.
I just think on Creighton, the conclusion was that there were more studies needed filtering efficiencies and the different types of masks. So I think that just want to make sure we're clear on what the final summary on that was. I'm just looking at the chat, and someone has asked that could you comment on Madeline Ashcroft's comments?
Yeah, and that's where I was going to go next, Natalie. But I do want to say to everyone, so normally when we do a webinar with IPAC, our normal meetings are 1 hour. When we do a webinar, they're up to 2 hours. And I had booked this meeting for 90 minutes. So we do have some time available if people are willing and able to stay on. If Dr. Leung, if you are willing to stay on. We do have a number of other questions that would be really nice to get to. So please, if you can, stay. Let's continue the discussion. So yeah, so Madeline Ashcroft had asked the question, IPAC Canada follows the recommendations of PHAC, which does not state that COVID-19 is transmitted by airborne route, although aerosols are agreed. PHO is the same. Until such times as these organizations agree with Dr. Leung, IPAC Canada will not state it's airborne. It would be interesting to hear Dr. Leung's thoughts on why only CDC US is requiring N95s for COVID versus the World Health Organization, PHAC, PHO, et cetera. Thank you.
Yeah. So I would say that WHO has been slow and PHAC has been slow. We have seen a shift on November 12th from Dr. Teresa Tam, our Chief Public Health Officer. I think that I can't say what's going on in the background, but from an outsider observing it, I would say that the announcement by Dr. Tam and the change on the website guidance is a huge shift in the position of Public Health Agency of Canada. Number one, the PHAC website now says that people in the public should and can have N95 respirators. Dr. Teresa Tam on Friday, November 12th, tweeted that exactly this. Think of this as what many of the aerosol scientists have been saying for a long time. COVID or SARS-CoV-2 travels like smoke. It accumulates in poorly ventilated spaces. You have a large concentration of these particles and they linger in the environment. So going into a room with individuals, even if asking, is still a risk. So really re-emphasizing the mode of transmission. Now, they have talked about aerosols. These small particles are called aerosols. They have not used the word airborne. Now, why that is, personally, I think it's a way to socialize and normalize this now for Canadians. If you can tell them exactly how this is transmitted with a description that is a description for an airborne pathogen, that maybe tempers the attention that it gets. And this was initially quite, actually announcing it and changing it subtly on the website on Friday afternoon does make it difficult for others to really know the impact of it. But I think that it is our jobs to communicate to the public and to our peers the mechanism of transmission. Whether you use the word airborne or not is debatable. Some people are saying, well, it doesn't really matter because you've already described how it's transmitted, which fundamentally is equal to airborne transmission, because that is the definition. So I think to some degree, there's still this debate, should we describe it as airborne and should IPAC Canada change it? I think what IPAC Canada should do is look at the current level of evidence, and a good summary of it is from the Clompus paper in the Annals of Internal Medicine, because this is reaching out to an audience already outside of IPAC. And hopefully that will then persuade our community to adapt some of these changes. And I don't see a problem with IPAC Canada taking a leadership on this, say that, you know, things have changed. Dr. Tam said it from the beginning, we've learned a lot from this, and now is the time to be very clear about it. IPAC Canada can do the same and say that we've definitely learned a lot, we've reviewed, and it's best to take the safest route that is achievable. It's not achievable to change all your hospital rooms into airborne infection isolation rooms. It's not achievable to even, for some places, increase the number of airborne infection isolation rooms, but it is achievable to identify places in your hospital where there is higher risk, and make it accessible to your healthcare workers who want to protect themselves, and not create a culture where we say, oh, you're not doing an HMP, why are you wearing an N95? N95, like we said, is a personal point of care risk assessment. Point of care risk assessment can, in some places, be done for the hospital itself. You can identify areas in your hospital where your healthcare workers are facing a higher risk of uncertainty because of either incidents in the community, people where you're transferring from different places in the province, and increase the use of respiratory protective equipment. And although in some of the hierarchies of controls that we've seen that say masking or PPE is the least effective. Actually, I would turn that around. In many contexts, it's the most effective for your healthcare worker because that is the only option your healthcare worker has to protect themselves. They will not know how many air changes you might have in that space. What they can do is empower themselves to use personal protective equipment when they see risk increase. And that's what we've done in our hospital. We haven't said that everyone must wear an N95 all the time. We, in Vancouver Coastal, where we are, we still have a very low incidence now compared to other areas in the province. When we have transfer of patients from, say, interior or northern health, that may be the higher risk time. We do rapid testing, and if we identify a case, then all healthcare workers on that unit are offered self-testing as well as encouraged and told to wear N95s for the time being, because we don't know how much transmission is going to happen from this exposure event when we have exposures. And through that, we've been able to control clusters much more effectively. And I think that just came from being on the taking a wrong approach in some of our larger outbreaks we've had in long-term care and acute care, and learning from that.
Wonderful. On another subject, but definitely related to environmental hygiene, but different than PPE, a couple of questions have come up about one for filtration, another one for UV. And so the question was, should we consider adding, air filtration? And the other one was, can you describe what upper air UV is?
So for the air filtration part, I think it's very important to talk with the experts in your area, because every building itself will have differences in the HVAC system, how it's designed, how it's maintained. And if it's not maintained or assessed, then really you have no idea. You can't rely on how it was originally designed to be the current state. We know that things happen throughout time and renovations are done, things go off balance. So it's important to involve your HVAC experts in your facility to first understand, okay, how do we know that what we're saying in terms of how our HVAC system works is truly working? So do your assessments, do your measurements, and then also establish how much outdoor air are we bringing into this environment, into this indoor space? What are they set it at? Is it feasible to continue this during a heat wave, for example? And it wasn't during our heat wave in BC, so things have to be adjusted. How much energy is it taking now in your system to bring in outdoor air, yet maintaining comfortable temperature in your environment? So those are all things that you should be relying on the expertise of HVAC experts. Professional deference, your deference is very important, I think, in this area. Have that assessed, and then ask them what the options are and evaluate those options in terms of cost, ability to make those changes for the short term, and the impacts it will have in the long term if you improve your filters or change airflow. If you are in a bind and you need to make improvements quickly, such as in a large outbreak, what we've done is we just brought in portable HEPA filters. Now, the portable HEPA filters will interact with your HVAC system if not placed and assessed properly. So first of all, you really should have an understanding of what is the clean air delivery rate of this portable HEPA filter? What is the estimates in terms of that portable HEPA filter making an impact on the size of your room at which you're placing it in a 4-bedroom, for example, or even in a single room? And those are all attainable through resources online, free resources we can draw you to, but also in collaboration with your engineers, your HVAC experts, to install these properly and quickly. A lot of these are plug and play, but if you purchase a HEPA filter that only has a clean air delivery rate less than 100, you probably won't be achieving much benefit, or as much benefit as if you could bring one in that's much higher. Of course, there's always going to be trade-offs, the noise, the energy that it takes, but in the short term, that's how I think you can reduce transmission if you bring in ventilation and filtration properly. With upper room UV, we know that UV itself has impacts on pathogens, and the UV length, the UVC range that has the most impact on SARS has now been increasingly studied. I think it's around, Gary, correct me if I'm around 266. I think in some studies show that that is kind of the UV range or the UV.
254 is typically what's used for the fluorescent UV.
And I think it could be 254 to 266 around there. But knowing that proper wavelength as well as how you place these to achieve airflow into the, because we know that depending on temperature differences in the room, air can either stay stagnant or rise. Hopefully, if you have good airflow, you'll understand where at least air may predominantly be moving. In places where you don't have that understanding, you'll need experts to come in to help advise on that. And what this does is it allows the air to pass through UV light that's protected from the other recipients in the space and basically cleans the air that way. And so it is another method to improve indoor air quality as it relates to infectious pathogens.
I hope
in some cases than creating, well, definitely than creating an airborne infection isolation room.
Right. We have a couple of other questions. How do we address multi-bed patient rooms?
Yeah, that is very challenging. We've seen repeatedly in our own outbreak management and published risk factors for transmission, and multi-bed rooms being one. And it may not necessarily be just people resting in their bed. It may be what's happening when people go to the washroom. We know that these shared washrooms, many places are very poor ventilation. They only have an exhaust that may not be maintained well. And so sharing that airspace in the washroom could be one of the large risk factors. But inside a 4-bed room, we did some preliminary airflow assessments using smoke pens and smoke bombs to really show that, hey, our understanding of how these exhausts work is actually not good, because there's dust bunnies that have accumulated in many of these exhaust grills that only allow airflow through a small area when we tested it with an air pen. So a good assessment of a 4-bed room would be helpful. And then getting your engineers to clean the exhaust grills, have an established maintenance schedule that at least IPAC should be informed about. Something that makes sense so that there's accountability and communication between your facilities team and your infection prevention and control team in the unit. In terms of 4-bed room management, what we've done on our COVID ward is put in for a short-term measure these portable HEPA devices when we have a cluster or transmission or an exposure in a 4-bed room that's high risk based on the viral load of the individual, of the index case, as well as how long they've been there. We're able to get a pretty good sense of what is considered high risk or low risk exposure. And in those cases, we will bring in a portable HEPA filter and test patients with rapid antigen testing for the next 7 days. In some cases, we detect individuals, move them out, and start to count. The reason we go with 7 days is because the serial interval of Delta is around 4 days now. So it gives us a pretty good sense that we don't need to continue sometimes these measures indefinitely, but in a targeted way when we have transmission clusters. And that's how we've dealt with 4-bed rooms. Once we have a cluster exposure, high risk exposure, we keep that bed closed. So unfortunately, it is a problem for bed access for patient flow, because we don't want to bring in new patients who are susceptible into that room unless we have recently recovered individuals. So these individuals who are no longer infectious, have been infected in the last 3 months, they can go into those exposed rooms without creating added risk. So that's how we kind of balance bed flow with use of 4-bed rooms.
Can you comment on nasopharyngeal scoping and airborne transmission?
Yeah, so nasopharyngeal scopes, you said?
Scoping, yeah.
Yeah. So in our ENT clinic, I mean, they do so many procedures there. ENT itself, I mean, in the sinuses, it is a very vascular area, and the amount of time that's spent in the upper respiratory tract in individuals can be prolonged. So what we've done for some of the clinics is assess the airflow. I haven't seen specifically how much scoping itself introduces aerosols. I think that would have to be looked into to provide a better understanding of the actual risks in aerosols, because we've seen now that intubation is low risk, and it's low risk because we oftentimes are doing rapid sequence intubation where people aren't actively coughing. Extubation is higher risk because of the coughing procedure that it could cause. Use of these laryngeal masks now instead of intubation have also been shown to be low risk of aerosol transmission. So I would guess that nasopharyngeal scoping could be dependent on whether you introduce sneezing or coughing, how much paralysis there is, because they will use lidocaine spray. And so that decreases the risk of introducing coughing and sneezing. But our ENT staff wear N95s when they're doing these procedures until that physical science evidence is available.
Okay. I have a question here. Thank you for your presentation. My question is, how do we stop the slippery slope of shifting all respiratory illness to being airborne and labeled? I agree that aerosolization is a significant issue with SARS-CoV-2. However, aerosolization does not necessarily equate to truly airborne, i.e. C. diff spores can be aerosolized, but C. diff is not considered a primary airborne mode of transmission.
Yeah, so I think one way that it has been introduced into the literature and then misinterpreted subsequently for this preventing the slippery slope is to have segregate these airborne modes into what we call obligate or opportunistic airborne transmission. So obligate transmission, these terms were introduced by Don Milton. I just learned this yesterday from some colleagues in a chat group that this was introduced by Don Milton to characterize transmission through the airborne route into different pathogens' ability. So an obligate airborne transmission pathogen means that the only way in this disease could be transmitted is through aerosols and the airborne pathway. So an example of that is Mycobacterium tuberculosis. He introduced this term opportunistic because not all, to introduce this idea that a pathogen can create disease in different ways and not just through one route. So example, I guess, would be SARS-CoV-2 in that, yes, droplet transmission through direct impact on a mucous membrane and then attachment to a humanized ACE2 receptor can lead to disease. That is means that a disease can be created in different ways, and that it doesn't necessarily just mean that airborne is the only route. But people have misinterpreted that and said that opportunistic just means that the Public Health Organization of Ontario, Public Health Ontario misinterpreted this, saying that the opportunistic transmission just means that it occurs in certain settings that are limited, such as when you have highest risk settings. And that is misinterpretation of how these terms were introduced. So I think that looking at Don Milton's introduction of these terms around airborne pathogens will allow us to better, and if we interpret it correctly and communicate it correctly, will allow us to better understand how these, where our interventions will have the most value. And so that would prevent us from saying that everything has to be treated in an airborne manner. I think that our approach to these diseases, of course, have to do with the significance of the disease and the mortality it causes, with SARS-CoV-2 still being a new disease with many consequences that are not yet known, such as the multi-inflammatory complications that can develop, multi-systems complications, as well as long COVID. With so much uncertainty, I think it's still prudent to be treating this with our highest levels of protection as an airborne illness. With some of these other colds, respiratory viruses, RSV, yes, it can cause disease. Maybe we should change some of our practices, but it doesn't mean that everything all the time has to be dealt with maximal airborne protection. But I think in the right setting and the right disease that we're looking at, with the understanding of the consequences and how to best control this disease so that we don't get ongoing transmission resulting in mutations developing and potentially worse, more transmissible viruses, we really need to be taking this seriously at this time to maximize our protections for this relatively newly identified emerging respiratory pathogen.
Right.
And how we deal with future respiratory pathogens. We should start from a different level. And in fact, we did. WHO actually has in their a guideline saying that if you're dealing with a new respiratory pathogen, you take this highest level of protection. It was this rapid shift by the WHO because of what was practical at the time.
Right. Okay. And I think the last question actually presented as more of a statement, but I appreciate your comments on it. Dr. Vipond, remember in regards to survivorship bias, shouldn't look at the number of people that didn't get COVID despite current contact droplet precautions. Need to look at the number of people that got COVID with current contact droplet precautions. Strong evidence that upgrading to airborne precautions would have prevented a significant number of healthcare worker and likely patient infections. Do you have a comment on that, Dr. Leung?
Yeah, I agree. I think one of the ways we try to recognize bias is look at the totality of the evidence and not let our minds kind of be narrow and just keep showing or finding evidence that supports our underlying biases. I think the proponents of those groups that have said this is airborne have been very open and trying to look at the totality of the evidence. But when people claim that this is primarily through droplet and contact, in fact, we haven't been able to find anything that suggests that. And looking at the balance of information, knowing that the absence of evidence isn't the evidence of that this doesn't occur, taking to mind that principle as well, looking at the totality of evidence, I would say that we should be very open to looking at things from different views. And of course, for what I think Dr. Vipond mentioned about for those who fortunately haven't been infected using the existing PPE, luckily you're immunized now, so your risk again is going to be reduced. But you shouldn't disregard this huge body of evidence of healthcare workers getting infected when doing and following all the instructions we've been giving them. But unfortunately, the instructions were inadequate because the tools that we were using were suboptimal.
Wonderful. Okay, well, thank you very, very much, Dr. Leung, for a very engaging and informative presentation. And wish you all the best. Stay safe. And again, thank you very much.
Thank you. I hope we can have more discussions about this at maybe at one of the IPAC Canada conferences when we're able to get together again.
Okay. All right.
Thank you.
And with that, we're going to open up the floor to the environmental hygiene interest group members for volunteers for chair, vice chair, and secretary. And so please indicate in the chat if you would like to be considered or put your name forward for chair, vice chair, or secretary, and then I'll open up the line for you. Okay, so no volunteers at this point. So I think we'll continue to kick the can down the road then. We have sent out a survey to the members. And so please complete the survey by the end of the month, by November 29th. And please feel free to volunteer someone to step up to the role of chair, vice chair, or secretary. And anyway, thank you all very much. Our time is pretty well up here, and I wish you all the best. Thank you for everything you do out there all the time, and for your advocacy for safety for patients and staff. We really, really appreciate it. So thank you very much, everyone. Take care.